This is wonderful. This is wonderful. I'm so happy to see you all here. If I get weepy, don't worry about it. It's not because I'm sad, it's because I'm so full of joy to see all of you spend your time listening to the doctors and absorbing the information that they have for you. If you feel like you're confused about something, for heaven's sake, don't hesitate to ask. I love the people here. Dr. Robertson was the diagnostician for my first wife. It's a relationship that's never been broken. And I hope that you find the same in the doctors that you visit with. Because for the people who are left behind when their loved ones pass, this is all we have. Their knowledge in our hearts and our minds. Bless us with the ability to care for our loved one. I don't want to talk too long, but I will.
12 o'clock noon, folks.
No, this is just such a wonderful treat for me. I haven't seen Dr. Robertson in a long time. I haven't seen the other doctors in a long time. But I know that we're connected. I know that I'm connected to these people who are so willing to help. Don't hesitate to have a conversation with your spouse's doctor or your doctor. They know. They have the information that you and I need. Ask them. Oh, please ask them your questions. I love you all. I've got a kidney problem. I can't stand up very long, but God bless each one of you and have a wonderful, wonderful meeting. Thank you very much.
Thank you, Don. That was wonderful, just as the true wonderful person you are. And so without further ado, I would like to introduce Dr. Stephen Vernino, who is from the University of Texas-Southwestern. And he is our host physician, and he's going to introduce the expert panel that he brought with him. So it's all yours.
Well, good morning, everyone. It's certainly a pleasure to be able to help organize this, and I welcome you. It's great to see a big group coming from a lot of different places, and certainly for the folks who are patients of mine, it's good to see you here too. So I've gathered a few of my colleagues to tell you a few of the things they know about multiple system atrophy. Obviously, we don't have all the answers, and we have many questions as well. It's a challenging disease. But there's some light, and we'll end the presentations with Dr. Robertson, who's going to hopefully give us some insight on what might be coming as far as some new ideas, some new treatments. I appreciate all the optimism, the dedication you all have to each other, and it's through a community that we make progress in diseases like this. So in terms of today's program, I've organized it sort of to talk about some of the core features of MSA, many things you may already know, but just to give you our perspective. And then we'll also try to focus on some hints for management. Again, some things you may already have heard, but maybe to supplement what you already know. And then, of course, as Don said, plenty of time for questions at the end. If you have a burning question and you think I might forget that question if I don't ask it just this minute, that's fine. We're not going to hold you up on formalities, so we'll just interrupt and we'll go from there. So without further ado, I'd like to welcome my good friend and colleague, Dr. Chitnis. Shilpa Chitnis is the Associate Professor in Neurology and Neurotherapeutics at UT Southwestern Medical Center here in Dallas. She's also the Fellowship Director for the Movement Disorder Section, and we've been working together for a number of years seeing patients with Parkinson's disease and multiple system atrophy who have trouble with autonomic function. So she's going to give us an overview of MSA. It's multiple system atrophy because there's multiple ways that and multiple problems that patients can get, and she'll kind of walk you through that. Following that, Dr. Praveen Kamani, also in the movement disorder section, will tell us about the management of the motor part, the motor problems, the movement problems that are associated with MSA. And then Dr. Srimupidi will talk a bit about the autonomic problems. And then we'll have a break after that and we'll start again. Okay, so without further ado, I'll turn it over to Dr. Chitnis, and welcome.
I might be able to speak louder and you would hear without the mic, but I think we need the mic. So a couple of things I'll say. If you think I'm going too fast, then do that. So I'll slow down. Okay, us Indians tend to speak a little faster than normal people. So my goal here today is, excuse me? Oh, there's a remote, yes, I have it, okay. So my goal here today is to really walk you through some of the clinical features of MSA or multiple system atrophy. Just to give you an outline of what I'm going to cover. So, and sorry. Which is this one? Oh, there you go. Oh, for whatever reason I'm pressing. All right, let me try a different way. Oh, there you go. Finally got it. So the outline of my talk, I think it's really important for us to understand some terminologies because, multiple system atrophy is a complicated disorder, and unless we really understand what each of these things mean, we won't understand about the disease. So I put a couple of slides in there to just understand some of the terminologies. Just a brief walk through the history of how MSA was basically described, and then we'll define what it stands for, cover some epidemiological features, and then finally, signs and symptoms of the different subtypes, and I'll summarize everything that I put together on my slides. So we'll start with the first terminology, which is Parkinsonism. We're all familiar with Parkinson's disease. We know some important people, Michael J. Fox, Janet Reno, who have what we call the garden variety idiopathic Parkinson's disease, where there is a deficiency of a chemical called dopamine. But there are disorders that constitute Parkinson's plus syndromes, MSA being one of them. So it means that there are some Parkinsonian features, plus in addition, there are other features which make us think that this is not a garden variety Parkinson's. And those ism means something that resembles Parkinson's, and so that's the terminology. So what are some of the things that constitute Parkinsonism? Bradykinesia means slowness of movement. Getting up from the bed is difficult, walking is slow, reduced arm swing, activities of daily living can be slow. Rigidity is stiffness, but it's not stiffness in the joints that people get from arthritis. This is stiffness in the muscles. The third terminology is tremor, and tremor, as you all know, is really shaking, and it's a rhythmic, synchronous oscillation of a body part, and so that's one of the things that you see. But in multiple system atrophy, we can have a little different kind of tremor. We call it a jerky tremor, and the terminology for that is myoclonus, and you'll hear that a lot. Did you have a question? No? Okay, thanks. And last but not the least, postural instability or balance problems that causes people to be at risk for falls. So these are some terminologies. So that's one aspect of MSA is Parkinsonism. So I wanted to walk you through those. And just to show you a little picture, this is a person with Parkinson's disease. They shake, they're stooped, as you can see. Their facial expressions are reduced because their facial muscles don't move as much. So that results in a mask-like face. Because of the rigidity or stiffness, the arms tend to be flexed at the elbow and they don't swing their arms as much. They're bent over, as you can see. And in the tremor, that's in the hands. And then they take short steps and they tend to drag their legs or shuffle. All right. So the second part is, we talked a lot about autonomic dysfunction in MSA. So what does autonomic really mean? So there's the nervous system is divided into central, which is the brain and the spinal cord and different parts of the brain. And then there is the peripheral nervous system. So the autonomic nervous system is part of the peripheral nervous system. And what does it really do? It controls some of these functions that are not in our conscious awareness. For example, if I pick up my hand, I'm aware that I'm doing that. But blood pressure control, controlling heart rate, controlling respiratory rate with breathing, salivation, sweating, the pupils, which is a small area in the eye that you see that responds to light, the diameter of the pupil, the process of passing urine, transit through the gut and how digestion occurs, and then sexual function per se. These are all autonomic functions that are not really in our conscious awareness. They just automatically happen during the course of the day. So I wanted to show a little cartoon. So this part here, B, is a structure that's called pons, P-O-N-S. That's one of the structures that is involved in MSA. And in this part is basically part of the medulla, and that's called the olives. And in this cauliflower-like structure here is really the cerebellum. And cerebellum is the part of the brain that is responsible for smooth coordinated movements. Okay? So as I said, cerebellum is responsible for coordination of the movements. And when there is a dysfunction, then there is a breakdown or decomposition of the movements, and the automatic sequencing doesn't happen as well. You will hear the term ataxia, and it means a lot of different things, but in coordination, people have a wide gait. When normal people walk, they have certain stance, but people with ataxia have a little broader gait. Dysmetria is the inability to control the range of movement. So for example, you're trying to do a finger to nose test, and you're all over the place trying to find the finger. Another terminology you will hear is nystagmus, and this is oscillations that you see in the eyeball. We usually ask the patient to follow our finger, and we can see that the eyeball's basically moving, and it can be horizontal as well as in the vertical direction. So that's nystagmus. Okay. So the third part of what constitutes MSA is the involvement of a system that's basically called the pyramidal system. And these are fibers. Actually, let me show you this picture, and that will probably help explain. So these are fibers that basically start in the part of the brain that we call the cortex, and then they fan down like this, and they go down, and then this is the midbrain going through the pons and the medulla oblongata, which is another structure, and then they cross over, and then they travel down in the spinal cord. And what do they really do? They control motor movements. So these are skeletal muscles that the fibers go to. Cranial nerves, these are some of the nerves that control functions, facial expressions, swallowing, speech. And so these fibers go through those as well. And so going back, these are motor fiber tracts. The voluntary skilled movements are what are controlled. And when these are abnormal and there is a dysfunction of these, then you can get weakness. So somebody has a stroke, then they're paralyzed on one side of the body. So that's motor weakness. And then when there is an increased tone, normally when you move your arm, the muscles have tone. And the tone can either go up or go down depending on the dysfunction. And so when you have a dysfunction of these tracts, that you have increased tone. And the terminology we use is spasticity. And then the reflexes, everybody's aware of the doctors checking reflexes, and these people have really brisk reflexes when you check them. And then one of the things that we do as part of the exam that you may be aware is we say, I'm going to scratch the bottom of your foot and look at the toes, and that's a test. And then if you see upgoing toes, then that's a sign of dysfunction of the pyramidal tracts. Or they're also called, because they go from the cortex, as you saw here, all the way down to the spinal cord, they're called the corticospinal tract. Okay? So complicated terminologies, but I want you to understand that. So I hope everybody has a little understanding of what we mean by Parkinsonism, what we mean by autonomic nervous system dysfunction, what do we mean by cerebellar dysfunction, and so we can understand the signs and symptoms a little better. So the second aspect, just to talk about the history, This is OPCA is based on the structures. It's olivo-ponto-cerebellar atrophy, and we saw all those structures in the cartoon. And this was described in 1900 by two gentlemen called Degerin and Thomas. And there's a lot more people involved. This, for time limit, I just put the main players in there. And then in 1960, 2 cases of orthostatic hypotension, that is fall in blood pressure when you stand up, and was described by 2 gentlemen. I think Shai was a neurologist and Drager was a urologist, and Drager is out of Baylor. So these are the 2 individuals, Shai and Drager, and this disease before used to be called as Shai-Drager syndrome or STS. And then going forwards, the term MSA or multiple system atrophy was coined by 2 gentlemen, Graham and Oppenheimer. And then pathologically, what do we see as a pathological hallmark of, you could look at the slide and say, yes, definitively, this is MSA. And this is the gentleman, Papp and group, that described what are called as there are glial cells, and there are certain inclusions in the cytoplasm or the body of the cell, and they're called glial cytoplasmic inclusions. It's a pathological hallmark of MSA, and this was described by these people. And then a gentleman called Quinn came up with the initial diagnostic criteria. How do we make a diagnosis of a disease? If we do not have a blood test, if we do not have a definitive marker that you can look on MRI, if we do not have tests that can tell us, at least clinically as a physician, when you first see somebody, then we use these clinical criteria to make a possible diagnosis or a probable diagnosis of the disorder, and can be confirmed by some tests you can do. So the question that we always get asked is, if my dad has it or my mom has it, what is the likelihood of me getting it? And so in general, it's a sporadic disease. It's not huge. There's not a huge genetic component, although there's maybe a couple of families that might have. But rare, mostly it is, we don't know what causes it. Perhaps there is a role for some environmental toxins. Usual age group that we see it in is people beyond 50 years of age. Maybe slightly more common in men compared to women, and Parkinson's disease is like that as well. And 6th decade is usually in the 50s, is when people first start to manifest signs and symptoms. So now let's come to the meat and potatoes, which is the clinical presentation. And so when we're looking at any combination of the terminologies that you learned before. So Parkinsonian signs, autonomic features, cerebellar signs, and pyramidal signs. And I walked you guys through those systems. So there's combination and involvement of any or all of these systems that gives you the clinical features. So we'll talk about, so there were terminologies in the past that you may be familiar with. One of them is Shai-Drager syndrome. There was striatonigral degeneration was a terminology. And one that we saw was OPCA, or olivo-pontocerebellar atrophy. And now the terminologies that we use are multiple system atrophy, Parkinsonian type, cerebellar type, and then one maybe with more autonomic features. So the MSA type P, more so Parkinsonian features. And so what are those? Slowness of movement, stiffness. You could have the jerky tremor. I have a video I'm going to show you guys. So tone, as we know, is muscle tone that we examine. This is dysfunctional or abnormal. And so abnormal tone can, there's a terminology called dystonia. So you can have sustained postures. You can have abnormal turning or twisting movements. So you can see this in the oral area, in the facial area, in the cranial area, which is the brain area, the face area, and then the cervical area is the neck area. So you can have these abnormal involuntary turning or twisting movements called dystonia that you can see. And dysarthria, simply put, is slurred speech. It's motor control of speech, and you can get this high-pitched volume that you might see. And importantly, balance is really compromised. These people are at risk of falls, Sometimes they can present with early falls as a presenting feature. So one of the things about MSAP is really in the initial stages can present clinically very much like your garden variety Parkinson's disease. And they may just present with slowness and stiffness and perhaps with a tremor at rest. And also, in the initial stages, one of the medicines that we use as a gold standard for treatment of Parkinson's disease is a medicine called levodopa. And dopamine is not something that we can give patients by itself, because you got to give a lot of it to get across to the brain, and patients can get nausea and vomiting. So there's a chemical formulation that's called L-dopa or levodopa that we use, and we say that one of the things is people with Parkinson's disease have a very robust response to levodopa. So if somebody's shaking, in the past, they used to use levodopa challenge tests. So somebody comes in and they say, you think they have Parkinson's disease, and the older physicians would give them a certain amount of levodopa in the clinic itself, make them sit outside, see them 30 minutes to an hour later, and you could see that they responded, their tremor is better, they're not as slow, their hand movements or their leg movements, their arm swing improves. So that's a levodopa challenge. And so in the initial stage of presentation, we can be fooled because these patients can respond to levodopa. But as the disease progresses, the benefit may be transient, and eventually that 90% of the patients do not respond. We have to increase the dose of the medicine to see whether they will get a dose response. But then the split side of it is, as you go up on the levodopa dose, your blood pressure can tend to fall, which is one of the components of MSA. And so we really need to be careful. And I know Dr. Mupidi will talk about this a little bit more. So one of the things that we see with levodopa use, even in Parkinson's disease patients, is they get these involuntary movements, and the terminology for that is dyskinesia. Anything kinetic is movement, this is abnormal, so these are abnormal involuntary movements. And if you're in medicine, everything has a terminology, so they're called dyskinesias. And then these can affect really the orofacial areas and neck muscles without really causing further benefit in the slowness and the stiffness, so without the motor benefit. And so the fully developed clinical picture sometimes can take a couple of years to evolve. And that's why when we see somebody with Parkinsonism, we really want to be careful as to how we manage them. And we check for, at each clinic visit, what we call red flags to see, is this going to turn out to be the garden variety Parkinson's disease, or is this going to evolve into a Parkinson's plus syndrome? And MSA is definitely one of the things that fools us. The other Parkinson's plus syndromes may have somewhat more definitive features that would help distinguish them early. So really, the clinical diagnosis is during the course of the follow-up. And we really like to be sure of a diagnosis before we give it to a patient. Of course, the definitive diagnosis comes from pathology, but there are definite criteria along with input from the workup or the testing that we do that will help us make the diagnosis. Excuse me. Thank you. The second category, everybody's okay so far? Everybody's understanding what's going on? Yeah? Okay. Speed is good? All right. So the MSA type C, and we went through these terminologies. So they have gait ataxia, meaning they have a unsteady, broad-based gait. They have incoordination of movement with the limbs. And then the scanning kind of slurred speech is, I can't do a good imitation. My colleague, Dr. Kemani, is a very good imitator. Maybe he can do it. But when people read, it's like reading cerebellar oculomotor disturbances. So it's almost like they're scanning each word. And this is a very poor imitation, so don't go by what I said. But essentially, they're like scanning each word, and then the speech is slurred and difficult to understand. And then we talked about the eye movement abnormalities. So, this is, you're pursuing a finger, and we call that pursuit. And in my case, it's a smooth pursuit, but in patients with MSA, there might be these jerky interruptions in eye movements, to be able to find that target. So the eye kind of keeps moving. And one of the things that I talked about we see is this movements that's called nystagmus. And okay, so again, there's a lot of causes for adult onset cerebellar degeneration, and multiple system atrophy may be just one of them, and in the initial stages may be indistinguishable. But there are certain features that definitely make it more likely, and these are the things that we're looking for. So dysautonomia, we talked about the autonomic nervous system. Abnormalities of the autonomic nervous system can be part of both of the presentations that I talked about. And so what are some of these things? So orthostatic is anytime you change positions, you're lying down and you sit, and you're sitting and you stand up. And some of you all may know when you go to the doctor's office that the nurse or the medical assistant will take the blood pressure in different positions. So you're lying down, and then they take your blood pressure and heart rate, then they make you sit up, and they make you stand up. And so we're looking for, is there a drop in blood pressure with changing positions? And in patients with MSA, this is very characteristic, and they can have like a 30-point drop. When you're looking at blood pressure, you look at two variables. The upper one is called systolic, and the lower one is called diastolic. And so you're looking for falls, so 30-point drop or 15-point drop in those may say, and the patient is symptomatic. There are some patients that are orthostatic on blood pressure measurement, but they're clinically not complaining of it. So they're not saying I'm lightheaded or I'm dizzy or I feel like I'm going to pass out. But when we measure their blood pressures, that there is a precipitous drop, and we want to be careful with that. So a lot of times we have dysfunction of the urogenital system, right? So in men, one of the things, these are embarrassing questions. Nobody wants to volunteer this information. But for us to be able to make a good diagnostic consideration, it's important we ask these. Are you having erectile dysfunction? And a lot of times you want to rule out other causes. People have prostate problems, people have had prostate surgery, people take medications that can cause these issues. So not a bad idea to refer these patients sometimes to urologist to get them checked out. But early erectile dysfunction in men, and then urinary complaints. So these are all part of the autonomic symptoms. So people can have incontinence, they leak, they don't have any control. They can have frequency, going more often. They can have urgency, I gotta go right now. And these are some things. And I guess perhaps in women, these things might be seen early as opposed to erectile dysfunction that's seen in males. And then constipation is really, so the reason people have constipation is because the transit through the bowel is slow, and this happens in all Parkinsonian disorders, including Parkinson's disease or MSA, and then medications can also basically contribute. And then significant number of patients have the orthostatic drop in blood pressure. And so syncope is passing out, and that's really related to the brain not getting enough blood flow, and that can happen from, as we said, the blood pressure falling too low. Sometimes people have rhythm problems. If you look at the EKG, it's basically, we say 70 to 80 beats per minute, and each of these beats are very consistent. So, the heart pumps like 5 liters of blood per minute, and that's because the heartbeat is very synchronous and rhythmic. In some people, you lose the rhythm, and it means that enough blood is not pumped out, blood flow to the brain is compromised, and so people can pass out, and that's called syncope. Or some people will have pre-syncopal feelings, meaning, I'm feeling lightheaded, I'm feeling dizzy, I'm feeling like I'm gonna black out, and then if they lay down or they sit down, then they may not go into the full-blown syncope. So, and then medications are really a trigger. So I think it's really important as a physician to look at what medications the patient is on. And the ones that we use for treatment of Parkinson's disease, one category of medications is called dopamine agonist. An agonist is something that mimics the action of dopamine. It's not dopamine replacement like levodopa is. And so these can definitely provoke or worsen the orthostatic drop in blood pressure. And when Dr. Mupidi and Dr. Vernino do the clinical testing, they ask patients to hold their blood pressure medications and their Cinemed, right? So that they can get an adequate idea of how much of the contribution is really coming from the disease and how much of it is coming basically from side effects of medicines. So a couple of other features is, so sweating I talked about is an autonomic function. And so reduction in sweating or lack of sweating, and those of you all who have undergone the autonomic testing know that this is a function that they check for sweating. Okay. And then we look for cold hand sign or cold feet sign, and the hands may appear to be cold, dusky. And this is, you can see it has like a little purplish hue, and that's called the violaceous appearance of the hands. And when we're doing a clinical exam, this is something we look for. Very importantly, from a safety consideration, one of the things was orthostatic hypotension, because that can get you into trouble if you pass out for too long, your vital organs don't get blood flow. The other important thing is respiratory function. So breathing, people have sleep apnea, which means that they may be snoring. Apnea is cessation of breathing, so especially at night, this is something to watch out for, because if they stay in the apneic stage for a long time, that compromises, again, the blood flow to vital organs. And then the vocal cords can be involved. Stridor is a kind of speech that we basically look for because of the tight vocal cords. In some people, the respiratory insufficiency. I actually had a young patient that was about 54 years of age that was really almost healthy, didn't have any problems, and presented with respiratory dysfunction, and he had respiratory arrest. They looked for I think his medical team looked for a lot of different things for why this may have been caused. And then as he evolved and we tested him, he really had multiple system atrophy. So in some patients, this can be a presenting sign. So we talked about stridor, hypoventilation, reduced ventilation to the brain is a problem and can portend a poor prognosis. So some more features going forwards. I talked about what dystonia is, right? Abnormal turning or twisting movements or abnormal posturing. And patients can present with, this is anterior enterocollis, is a forward positioning of the neck, and that's something that patients can present with. And then severe flexion of the trunk, that's a bent spine. We see this in Parkinson's disease as well, but we can see it And so this is, the reason these two pictures are different is this is how the patient is. And these are some sensory tricks that patients basically use, because this is a form of, dystonia, and patients with dystonia use these sensory tricks to get to somewhat of a normal position. So that's why these two pictures are different. An interesting phenomenon that we see is leaning of the body to one side, and that's called the Leaning Tower of Pisa syndrome, familiar. We talked about the dystonia involving the facial muscles. And so if somebody has pronounced Parkinsonian features and they're rigid and they're slow, and I won't go into therapy much because it's going to be covered later, but we try this medicine called levodopa, because as I said, initially in the course of the disease, the patients may be somewhat responsive. But we try to go up slowly, but even as we initiate the levodopa therapy, that it can bring on some of these abnormal facial movements, and that's important to keep track of. And then we talked about the laryngeal tightness of the vocal cords resulting in stridor.
This gentleman has multiple
Let's see.
system
This works.
atrophy.
All right.
He has
So I want to show you a patient video.
hypotonia.
Can you turn up the volume a little bit?
He has occasional saccadic intrusion.
And if it
into
doesn't come
pursuit
on,
eye
I'll
movements.
walk you guys through what it is. So they're checking eye movements, and if you can see that these are slow and they're interrupted by these movements I talked about before, that's vertical limitation, down gaze. With Parkinsonian features, it is definitely The progression is faster than what we see with the garden variety Parkinson's disease. We talked about, and this is a repetition, but I'm going to go through it quickly. Postural instability. As the course progresses, patients get in a wheelchair. We looked at the abnormal postures. Dysphagia is swallowing, difficulty, abnormal swallowing. And speech and swallowing are very intricately connected, and Janine will walk you through those. Slurred speech, respiratory dysfunction, that's very important to keep track of. Early autonomic dysfunction, you just saw the jerky tremor. I showed you a picture of the cold hands and feet. There's a sleep disorder. In addition to sleep apnea, there's a sleep disorder. REM stands for rapid eye movement, and these are different stages of sleep. And so there's a sleep disorder where the patient may verbalize, may talk, may yell and scream, may actually act out their dreams and kick themselves or the spouse out of bed. And this can be treated with medication, but this can be part of the disease pathology. And may have an initial good response to levodopa, but high risk of developing these involuntary movements. And then as the disease progresses, waning response, and then eventually not much response to levodopa. And so in terms of diagnosis, we really look at, there's a second consensus criteria. These were developed. The specific things we look at for basically possible, probable, and then definitive MSA is when we look for the pathological lesion that I talked earlier, which is the glial cytoplasmic inclusions. Certain findings on brain MRI, if actually you looked at my first slide, that I had this slide where, maybe I can go back to it later. And in autonomic studies, which is what Dr. Mupidi and Dr. Vernino do for us, this is a dopamine transporter scan that has been available in Europe for a while and just came to US. We have it. And this really tells us that there is loss of these terminals that make dopamine. It doesn't help us to distinguish between Parkinson's disease versus MSA versus the other Parkinson's plus syndromes, but we use this to distinguish between different kinds of tremors. There's a condition called familial benign essential tremor, and we have patients with that, and then we do the DAT scan, and that will tell us whether this is something Parkinsonian versus essential tremor, but does not help us to distinguish the different Parkinson's plus syndromes that we do clinically. Okay, so quickly, just to summarize, it's a sporadic, meaning it's not hugely genetic. Neuro is, the nervous system, and it's a degenerative disorder, loss of cells in the brain. It's rapidly progressive form compared to the garden variety Parkinson's disease, and we're looking for a combination of number of different features: Parkinsonian, autonomic, cerebellar, and then pyramidal signs. And then the subtypes that I talked about, MSA, P and C with autonomic dysfunction. Really, the troublesome areas to look out for to stay out of trouble is really speech and swallowing. You want to eat slowly. You want to eat softer foods. You want to take smaller gulps to avoid swallowing problems. Aspiration, food goes into the lungs, or drink goes into the lungs. It's a chemical pneumonia that's called aspiration pneumonia. Janine can talk more about it. Talked about sleep apnea and REM sleep behavioral disorder. Cardiac rhythm disturbances are part of the autonomic dysfunction. Urinary problems, if you have incontinence, that puts you at high risk for infections. If you're not very mobile, that puts you at risk for infections, and then falls can be a problem. So that's what I had to say, and we'll answer more questions if you have in the future. And thank you so much for coming here, and thanks for listening. And importantly, there's medical science, and there's things that we need to focus on, family support and hope in the form of research. So thank you. Appreciate it.
Okay, that was a good overview. I think we'll move on to Dr. Kamani. He's going to talk a little bit about the management of some of these things in terms of the movement disorders that go on. So there's probably a lot of questions, and hopefully we'll answer some of them as we go through, but keep them for later if not.
Thank you. I'm just going to just set this up. I'm not going to move a whole lot. Thank you. Can you hear me okay? Right. Good morning. Thank you for coming, and thanks for having us over. It's a privilege and an honor to speak
to you all this morning, and I thank my colleague, Dr. Chitnis, for setting the stage for the talk. That was a great overview. Some of my slides are going to be a little reiterative, and I'm just going to re-emphasize a few of the things that she mentioned with respect to the motor symptoms and the non-motor symptoms of multiple system atrophy. Let's get started. Simplistically, multiple system atrophy and other neurodegenerative diseases like multiple system atrophy are a collection of motor and non-motor symptoms. And I'm going to emphasize the treatment of the motor aspect of multiple system atrophy. However, in the body, motor and non-motor symptoms are not compartmentalized. They exist together, and hence the treatment of both motor and non-motor symptoms effectively leads to can be used in small doses and may also be effective in nystagmus that we had heard about, abnormal eye movements which cause a semblance of the environment moving or jerking. This is a great website, and I must say that some of this material that I presented today is from the Scheidreger's MSA website, which is excellent, and there's a direct link to this through the website. And I'll take you there, and you can actually access the website and look at the medications that are being studied in multiple system atrophy. And there are several drugs. The 6 that are listed here are being studied primarily for all the features of multiple system atrophy, but there are other drugs that are being studied for orthostatic hypotension and the dysautonomic features of multiple system atrophy. Fluoxetine or Prozac is currently being studied in France, I believe. Lithium is being studied in Italy. Intravenous immunoglobulin, I think, is being studied in Massachusetts at University of Worcester. Stem cell infusion, this trial was just completed in Korea, and we haven't heard anything about it yet. It's based upon some animal models in which bone marrow stem cells were transfused, and they saw a benefit in some neurodegenerative aspects. Rifampicin is being studied currently, and I think there's active recruitment going on for this medication. I think Dr. Vernino is one of the investigators at UT-Southwestern for this particular drug. Rasagiline is also being studied in a multi-center drug trial. In earlier stages of multiple system atrophy, as we talked about, medicines play an important part, particularly with respect to motor symptoms, combined with neurorehabilitation, which is important at all stages. However, with progression of the condition, you have increase in immobility. And thereby you got secondary problems. And we talked about some of them, but let's go through them real quickly. Contractures or decreased range in motion, and you may not be aware of contractures or decreased range of motion because there is significant redundancy built into your joints to perform your activities of daily living. So a significant amount of function might be lost before you realize that a contracture is set in at the shoulder or the elbow joint. Muscle wasting and weakness, primarily from immobility or not moving around. It's called disuse atrophy. Bone loss. Bone is what we call as a mechanosensitive organ. The more you load it, the more you move it, the more stable it is. The less you move it, you actually have bone loss, and calcium can leach out in the bloodstream and cause all kinds of problems. Skin breakdown can happen from immobility, and you know what pressure ulcers are. Blood clots, also called DVTs, which are deep venous thromboses, can happen from immobility. Breathing problems. Lungs breathe better if you breathe fuller and deeper. And if you don't do that, then parts of the lung can collapse and give rise to breathing problems. Gastrointestinal problems. Constipation is common in Parkinson's disease and other forms of Parkinsonism, including multiple system atrophy, and lack of mobility can worsen that problem as well. Decreased endurance, cardiovascular deconditioning can happen with increased immobility. And there are actually studies that show that there are neurotransmitter changes in the brain that can cause depression from immobility. So when the disease is progressing, these are the complications you need to be aware of. And if medications are not doing the trick or are limited, then neurorehabilitation becomes more and more important for the effective treatment of motor symptoms. So the equation changes. I want to definitely give a shout out to the website, which was very, very good. It has a great glossary of terms, and I got a lot of my material from there. Clinicaltrials.gov is another very good website for which will tell you about the current research in medicine, in multiple system atrophy. I'm sorry, and there's a couple others that you can access to learn more about MSA and its treatment. Thank you for your attention.